Hello, everybody. Welcome in. Sorry, I know I'm talking a couple minutes late. My, it always is funny. We stream to Facebook and YouTube, and sometimes that is just the easiest process ever, and other times it just doesn't want to work. And I was about to give up on it, but I think we got it. So that's good because if you ever want to watch this again, it'll be on YouTube after this. So I do like to make sure that we have it there so that if you want to revisit anything. But anyway, welcome. My name's Rebecca. This is the CCRN Rapid 30 that we're doing about monthly now. We just go through practice questions together. A different way to break up your studying. I know you're doing a lot of practice questions as it stands, and this is a way to sit down with a CCRN certified nurse and just walk through the rationales together in a live format. And it's super fun. I really enjoy these. I love interacting with you guys. Let me know in the chat if you are already using the Archer Review CCRN course, if you're maybe here to just check out and see if you like the teaching style. Kind of get a feel for it, or if you're actively preparing for your CCRN, when are you taking it? When is your test date if you're already scheduled? Um, what type of ICU you work in? Give me anything. While we talk about that, let me share my screen. I will talk a little bit about the CCRN, just to make sure everybody feels good about what we're talking about here. Um, and again, would love to hear from you. So use that chat box to tell me where you're from or um, again, what type of ICU you work in and when your test is. Oh, somebody is saying they passed their CCRN exam thanks to Archer Review. Thank you so much for coming back and telling us. That is awesome. Emmanuel. Yeah, thank you. Congratulations. Okay, Victoria, Medical ICU taking your CCRN this month. Congratulations. That's awesome. Medical ICU is such a good background for this exam. You see a little bit of everything in medical ICU, and that is really helpful for this general ICU exam. Yeah, you got the Black Friday deal. Awesome. That's good. That made it like such a good price. So I was so happy that we were offering that. Um, Sometime next year, have finally finished your full year in the CVICU. Congratulations. I started in the CVICU. Great place to start. I know it's a big learning curve, but um, it's I learned so much by starting in the ICU. When you start off anywhere, you learn so much as a nurse, right? Passed NCLEX through Archer, working in MICU for 4 years already. Back to Archer for CCRN review. That's awesome. I'd love to hear it. Surgical ICU, no test date. Want to watch all the webinars first. That's awesome. Um, yeah, we've got lots on YouTube. There's a whole playlist up there of webinars. And then if you ever do decide to use our product, I am the one who teaches all the course material for our CCRN product. So definitely make sure you like the teaching style first. It seems to be working okay for most people. From Chicago, working in ICU, just enrolled. Awesome. Okay, guys, so exciting. Thanks for interacting. A little bit about the CCRN. I'm going to breeze through this because a lot of you probably already know a lot about it. It's obviously a critical care nurse or certification. You can test after about a year of full-time experience, even a little bit less. You've got enough hours. It's 125 counted questions. You'll sit for 150 total, and you need 83 correct to pass. Um, it had a 72% pass rate last year, which I think is down. If I remember correctly, we were in the 80s the year before. So the pass rate's going down. Now, a new test plan just released in November, so that might adjust things slightly. I will say that the new test plan is not um, there's no super significant changes for the news test plan. Basically, all they did was adjust the percentages that certain body systems take up on the exam. So it used to be that cardiac was a solid. Again, I'm working from memory. I should have written the numbers down. Cardiac was a solid like 17% of the exam, and now it's lower. Now it's more like 14%. They just moved some of those percentages around, which is really insightful to know as you're trying to determine how much time you spend on a certain body system. I know for me, for the longest time, endocrine was really rough. I feel like I've finally gotten a handle on it, but for a long time, I really hated endocrine. And I looked at the CCRN test plan and I saw, oh, it's only like 3% of the test. I'm not really gonna make myself worry too much about this because I already know that I don't like it. But some of those percentages have moved around, so then you can kind of use that as a guide. Archer review for CCRN, a lot of you are already using us, so super exciting. We've got 14-ish hours of on-demand lecture content broken down into bite-sized pieces, so you can watch the video lectures that are pertinent for what you're looking to understand or go through the whole course. And then we have over 1,000 questions in our Q bank, and we're constantly editing and making that Q bank better. So look out for changes there. And then we do these free webinars, usually around every month or so, just to get some interaction time, mainly because I love it. And I love hearing that people are taking their CCRN. I think it's a really good thing to do for your career. Hopefully, your hospital pays you more money. If you're looking to going back to school, it's obviously good to have, but it also just increases your confidence at the bedside to have really great conversations with providers and patients. So, big advocate for the CCRN here. Okay, awesome. Let's go ahead and get started. Like I said, we're just going to go through practice questions. We're focusing primarily on shock states today. Um, and please interact with me in the chat. I am the only one that can see your answers in the chat. So throw your answer to the question in the chat. That way I know where people are thinking and we can talk through the questions a little bit better. Okay, let's start here with question number one. 64-year-old male with a history of diabetes is admitted with fever, hypotension, and altered mental status. Lab results reveal a lactate of 4.2, white blood cells of 18,000, and a MAP of 58, despite fluid resuscitation. Which intervention is the highest priority? We have A, initiate vasopressors, B, administer empiric broad spectrum antibiotics, C, initiate corticosteroids to reduce inflammation, or D, obtain a central line. Awesome. Good job, everyone. Couple different answers here, which again is actually always so exciting. When we do these questions and everyone gets the same answer, then I don't really have that much to talk about, if it's right. So it helps. That means we've got things to learn, which is exciting. And CCRN questions, I'll just be honest, while everyone's answering these questions, I'm sorry if you can hear my dog barking in the background. Hopefully you can't. Um, when it comes to these questions, CCRN questions are difficult. They're not trying to trick you in the way that NCLEX questions are, but they are hard questions. So, a lot of times when you're taking practice test, if you're getting in that 70s percentage area, you're probably ready to test because these are difficult questions and you need a 67% to pass the test. So, just keep that in mind. Okay, let's go ahead and talk about this. So the two answers that I saw most commonly were A and B. The answer here is going to be A, initiate vasopressors. And like I said, the other answer that I saw most frequently is administer those antibiotics, which obviously, what type of shock state do we think this patient is in? If anyone wants to type that in. What do we think's going on here? Yeah, this is classic septic shock, right? We've got an elevated white blood cell count, really lets us know that there's an infectious source. And we have a low MAP. Our MAP is 58, which tells us we've entered from sepsis into a true septic shock where we've got that refractory hypotension that fluid resuscitation has not fixed. So we know in septic shock, we're really vasodilated. And a lot of times fluid resuscitation can kind of help that out if we're just in sepsis. But as soon as we're in that septic shock and it's gone a little bit too far, we are going to need vasopressors. And the reason that that is our first line is that we have a hypoperfusion problem. So simple ABCs, airway, breathing, and circulation. We want to fix that map before we fix anything else. Does this patient absolutely need antibiotics? And actually, I hope that they're already started on them. Yes, but we're going to fix that vital sign first. So excellent job, everyone. Those were definitely the two best answers, and I didn't see any other ones. So that's really good. Let's go to the next one here. Question two, a patient presents with suspected sepsis and is developing acute respiratory distress syndrome or ARDS. Which physiological response underlies the development of ARDS in sepsis? A, sympathetic overaction leading to alveolar hemorrhage. B, hypoperfusion causing ischemic necrosis of alveolar cells. C, inflammatory mediator release causing increased capillary permeability. And D, microthrombi formation obstructing pulmonary capillaries. So this is a anatomy and physiology, or really a pathophysiology question. Good job. Answers are looking good. Good job, everyone. I'm really impressed because this is a wordy, the stem of the question isn't that wordy. Some CCRN stems can get really lengthy, especially when we get into hemodynamic profiles. Um, but the answer choices to this question in my mind are very not necessarily wordy, but there's just a lot going on. And a lot of these we could say are absolutely happening in sepsis. So we are seeing the sympathetic nervous system taking over, right? As a shock response. We are seeing hypoperfusion because we're typically hypotensive in a shock state. We are definitely seeing inflammatory mediator release in sepsis, and we can see microthrombi formation if that sepsis transitions into DIC, which is a complication of sepsis. So each one of these answer choices has something that is technically accurate to sepsis pathophysiology. However, you are all correct in saying C, inflammatory mediator release causing increased capillary permeability. That is the pathophysiology behind ARDS, acute respiratory distress syndrome, where we have that non-cardiogenic pulmonary edema. So it's not coming from a cardiac cause, like a backup of blood flow into our pulmonary system. It's coming from that massive inflammatory mediator release, telling the body systemically to increase that capillary permeability, leading to pulmonary edema. And that gives us ARDS. So y'all did an excellent, excellent job. Okay, got a little slide here on what that um, progression looks like from sepsis into ARDS. But we won't spend a ton of time there because y'all seemed pretty confident. Okay, let's keep on going with these shock questions. A patient in septic shock is on norepinephrine with a MAP of 65, SpO2 92%, and a lactate of 3.9. Urine output has been less than zero point 0.3 milliliters per kilogram per hour over the last 4 hours. What should the nurse anticipate next? A, increasing the norepinephrine infusion rate. B, beginning renal replacement therapy. C, add vasopressin to the current vasopressor regimen. Or D, administer a second fluid bolus. Yeah, I don't love this question, I'll be honest. I remember looking at this one before this, and I even thought about skipping it. So if you don't get it correct, don't think too hard about it. There's a couple schools of thought here. Okay, let's go ahead and talk about it. So the two answers that I saw the most were C and D, and that makes sense. Those are the ones to choose between for sure. The correct answer here is C, add vasopressin to the current vasopressor regimen. Now, like I said, the other answer that we saw a lot of was administer a second fluid bolus, and I don't hate this answer either. A lot of times, especially in practice, when we're looking at that patient that's on norepinephrine, which we can assume, and this is something you should assume if you are taking your CCRN and you have this patient portfolio. So you've got septic shock, they're on norepinephrine, assume they have been fluid resuscitated because obviously we're going to try fluid first. If we continue to see hypotension, that's when we start norepinephrine. And that's something that you can kind of rely on being consistent for your patient profiles for the CCRN. So if you see that septic shock patient and they're on norepinephrine, know that they've been fluid resuscitated. We're seeing that map kind of right at goal. But other things are telling us that even though our MAP is 65, we are not getting end organ perfusion because our lactate is still elevated and our urine output is not sufficient, meaning our kidneys are struggling. We likely need more of a MAP goal of around 70 for this patient if we're not seeing adequate urine output with MAP of 65. That's a good reason to increase our MAP goal. It would be standard in practice to either assess for if that person needed more fluid or add vasopressin to their vasopressor regimen. So the reason that C is the answer is because we are going to assess the need for that second fluid bolus prior to just administering it. More likely to just add a vasopressin to be specific, to their support, and at the same time, maybe see if they need more fluid. Again, I don't love this question. I feel like C and D, especially in practice, could one co-occur at the same time in the sense of assessing for that need for fluid bolus while you're adding on a second pressor or having just a really low threshold for adding vasopressin after administering a second fluid bolus. I think we need a little bit more context for this question. How much fluid did they receive in their initial resuscitation to kind of guide us a little bit further? Increased norepinephrine infusion rate, I don't like because we were never told what they're on norepinephrine wise. They could be maxed out. And it's clearly getting us to a MAP goal, meaning the norepinephrine's doing what we want it to, but it's not quite giving us end organ perfusion, meaning another form of pressor is going to be more effective for this patient to work in conjunction with norepinephrine. And then we're definitely not beginning renal replacement therapy with this specific set of details. Not quite there yet. Good job, everyone. I know that's a frustrating one. Okay, let's move on to the next one. I think I'm even gonna skip one here because I can see how much time we have left here. Alrighty. A patient with a recent anterior STEMI develops hypotension, jugular venous distension, and muffled heart sounds. Pulmonary artery catheter reveals a CVP of 18, PaOP of 20, cardiac index of 1.8. What is most likely the diagnosis? A, cardiogenic shock, B, right ventricular infarction, C, papillary muscle rupture, or D, cardiac tamponade. Good job, everyone. Yeah, okay. So this is pretty classic cardiac tamponade, right? We have our Beck's triad confirming those symptoms. So that's something for sure going into your CCRN. Feel very confident about your Beck's triad. There's a few other kind of key diagnostic tools, assessment tools, like Beck's triad that you can remember too for different conditions. And that is definitely worth your time. So we had that jugular venous distension, muffled heart sounds, and hypotension and narrow pulse pressure. Um, yeah, we had hypotension in there. And then it's further confirmed when we look at our pulmonary artery catheter. Our CVP of 18 proves that we're having a backup of blood flow into the venous system because we're obstructing, we're not getting blood out of the heart with how compressed it is in the form of tamponade. Our PaOP, so our left ventricular filling pressures are super high at 20, and our cardiac index is very low at 1.8, meaning again, we are not having forward flow. And that is indicative of tamponade. Great job. Let's keep going. A patient with acute decompensated heart failure and EF 15% is on dobutamine with a MAP of 65 and urine output of 10 milliliters an hour. Which next step is most appropriate? This kind of reminds me of that other one we did. Begin sodium nitroprusside. B, initiate mechanical circulatory support. C, increase dobutamine dose. Or D, administer furosemide. Hey, I think I've seen almost every answer choice, so this is a hard question. The other thing I will say, in case this is your first webinar with me and you haven't maybe seen other ones on YouTube just yet, I pick very difficult questions to go through on these webinars. And that's completely on purpose. I just think it's a better use of our time to go through pretty difficult questions where it kind of takes a lot of sussing out the answer choices and they're a little bit uncomfortable. They're ones that we're not going to leave feeling like, oh yeah, that 100% makes sense. I can totally trust myself to pick that next time. It's more to just practice with these pretty difficult questions where there's lots of answer choices that we could choose. Okay, so like I said, I saw a lot of different answer choices, so let's just take them one by one. Sodium nitroprusside. We do not have the there's a couple thoughts behind this. If you have a really poor ejection fraction, we can think, well, let's reduce our afterload, which sodium nitroprusside would help us do. Reduce that afterload to help our cardiac output, right? Unfortunately, our MAP is too borderline that we would not be able to safely begin that medication. Because we're on dobutamine as it stands and inotrope. And dobutamine already has a little bit of afterload reduction, a little bit of that vasodilation built into it. So we cannot safely add on another vasodilator. So A is not our answer. Gonna skip B for now. Let's bump down to C, increased dobutamine dose. Again, I will struggle with any time that the if the exam tells you that they are on a medication but doesn't give you the dose, I wouldn't do too much manipulation. I don't want to say it's a 100% of the time rule to say the answer is never going to be to increase that dose, but it's just we don't have enough information to say, yeah, just give them more inotrope. What they're typically going to want you to be thinking through is they're already on this one therapy. What else can we try because it's not working? What we're seeing here with this patient, they're in acute decompensated heart failure, really poor EF of 15%. We already have them on inotropic support. MAP is borderline, technically at goal, but we're again missing that end organ perfusion that we kind of similar to that other question, where that urine output is low, meaning our kidneys are not getting enough perfusion. Regardless of the fact that our MAP is 65, we are still struggling to perfuse. And this is where it's going to be critical to really look outside of the map. The CCRN is really going to want you to think about perfusion as a really multifaceted approach. And your cardiac output and cardiac index play a huge role in addition to that map. So we can have a really solid map of 65, map of 70 all day long, but if we're not making adequate urine or a lactate is still rising or mental status is still not improving, those are signs that our end organs are not receiving enough oxygen or perfusion despite an adequate map. And that's what we're seeing here. So I'm not going to increase the dobutamine dose because I don't know what the dose is. And again, the goal of this question is to tell you they're already on that. And even though that map is 65, we are not achieving that end organ perfusion. D, administer furosemide. Again, recognizing here that the problem is perfusion and not necessarily needing to stimulate the kidneys with a diuretic at this time. So the answer here is actually going to be B, initiate mechanical circulatory support, which is pretty much our next option. When we have a acute decompensated heart failure patient and we have them on inotropic support, and maybe, yeah, maybe we've gotten that map up. We don't have any PA numbers here to tell us what does their cardiac output and cardiac index look like. We would love to see those numbers. That'd give us even more information, but we don't have those numbers. So we just know that that inotropic support is not really working. And there's a couple different inotropes out there that we can try. Dobutamine's a really solid one though. And if we're not seeing that effect and we have that borderline map, meaning we can't go any further with afterload reduction to get cardiac output higher, we really have mechanical circulatory support. That's really our next choice. And it seems kind of aggressive when you're only given three vital signs here, but again, it's recognizing that we've tried the inotrope, it's not working. We don't have end organ perfusion. We need some more afterload reduction and cardiac output improvement. How do we feel about that? Because I know we got a lot of different answers for that question, and I know it's a difficult one. Did that make a little bit more sense? Kind of walking through it that way. Okay, perfect. Again, these are tough. Like the CCRN is, I hate to say it, but it's not the easiest exam in the world. It's definitely more of a difficult exam, but I always say, and I'll spend the last couple minutes kind of talking through, a little bit of test taking tips with it. It's not trying to trick you, but it is trying to get you to think critically through that information. So really look at the information that it gives you and think through what exactly does this patient need to assess the cause of what's going on? And increase dobutamine, they're already on something and it's not working, it's rarely going to be to increase whatever's not working. Even though, again, we definitely do try that in practice. This is just, we're thinking a little bit more aggressively. The other thing that I will say for the CCRN, in case you haven't heard this piece of advice before, kind of think like you are the provider. And this is where it really varies from the NCLEX. The scope of practice is not what the CCRN cares about. The CCRN is not a safety exam in the way that the NCLEX is. It's not making sure that you're not going to act out of your scope. It wants you it wants you to prove that you can think through what that patient needs, even if what that patient needs is technically out of our scope to do ourselves. Like, we're not going to say, okay, we're throwing the balloon pump in, and that's our decision. It's not, but it wants us to look at that patient profile and think, this patient needs a balloon pump. And I can expect that that's what's coming next, even though we're not putting those orders in. That's one of my biggest tips for CCRN is don't be afraid to kind of answer out of your scope. And usually it's worded in a way that it won't make it feel inappropriate, but I've gotten that feedback from questions before with saying, well, I can't, it says to give this medication and I can't, say to do that. And that is, it does not care about your scope. It wants you to know what that patient needs. Okay, let's do one more question. Theoretically, there we go. Okay. Yeah, this is good. Another cardiac question. A patient post MI develops a new systolic murmur and sudden onset of pulmonary edema. Echocardiogram reveals flail posterior mitral leaflet. What is the most appropriate intervention? A, administer IV furosemide. B, begin nitroprusside infusion. C, emergent surgical consultation. Or D, insert an intra-aortic balloon pump. Very similar answer choices to the last one, even though it's a different um, presentation. What do we think for this one? Couple different answers. Again, that's always a good thing. Okay, let's go ahead and talk about this one. Okay, so we have post MI. So we know that this patient's experienced myocardial infarction. We might have some dead heart muscle tissue, which is what we're seeing here. New systolic murmur with a sudden onset of pulmonary edema. And then, we could start to draw some conclusions about what that could possibly be. But the question actually tells us what's going on. We have a flail posterior mitral leaflet, which can be suggestive of what? What do we think happened here? If we're seeing that on echocardiogram, sudden onset pulmonary edema, because we've got that mitral leaflet, so we know we're on the left side. What bigger condition do we think this patient's experiencing? We are seeing a papillary muscle rupture. We have that MI. If that MI is severe enough, it can completely destroy that muscle that holds on to the papillary muscle that holds on to the chordae tendineae. I think they're called. I feel like I always mispronounce that. But the chordae tendineae that hold on to the mitral valve and other valves in the heart. if we lose that muscle, we lose complete control over that valve. And mitral, that's acute mitral regurgitation, in the setting of papillary muscle rupture is a medical emergency. There is nothing we can do supportively to fix that problem. We do things in the meantime when we're waiting to get the person to surgery, but absolutely we need emergent surgical consultation. So that's our answer here. It's going to be C. We are going to get that patient to the OR to fix that valve. We cannot, a balloon pump cannot compete with mitral regurgitation. It's luckily not aortic regurgitation. That would be a contraindication. But still, it's not, the balloon pump really is a supportive device. It's not going to kind of unlike the Impella, we're not going to gain a cardiac output in addition to inherent cardiac output. It helps improve cardiac output, but not in the sense of like a motor actually creating cardiac output. IV furosemide might help in the short term, as we're obviously going to have major problems with forward flow with such significant mitral regurgitation, and getting some of that volume out of the heart so that there's not as much pressure for that forward flow. It might be helpful, but it's not going to fix it. Kind of the same with nitroprusside. Yes, reducing afterload could help a little bit with forward flow, but we cannot compete with mitral regurgitation that is that severe. And we know it's severe because it's coming from a papillary muscle rupture, which is evidenced by that flail posterior mitral leaflet. Flail meaning no control. There's no control over that valve at all. Okay, awesome. Normally here I go to a slide telling you to sign up for our next webinar, but with it being the end of the year, we have not made our schedule for the new year yet. So I don't know exactly when we're going to do one of these again. It will be in January and it will be posted to the website when that happens. So keep a lookout if this was good and helpful for you. Like I've said a few times, we've got a whole playlist on YouTube with a bunch of these reviews. I do, now that we've been doing them for we're a couple months shy of a year, I repeat some of the questions. So you might see some that you saw today, but there's still so many on there to look through. So definitely take a look at those and reach out to us if you have any questions at all. We are here to support you as you study for your CCRN. And yeah, that's about it. Anybody have any questions? Today's webinar recorded. It will be on YouTube. I see somebody asking on YouTube. So yes, it will be posted on YouTube. You'll just kind of have to, it probably won't fall into the playlist right away. Somebody kind of puts them in there, but if you go to Archer Review's YouTube page, you'll see it there under the live section. Okay, everyone, I will let you go. Thank you so much. Thank you for being so interactive, and good luck to everyone who's testing this month and in the next couple months. Very impressed with the answers that I saw today. I know these questions are difficult. All right, we'll see you